So we move on the next topic. We also investigate about the specifically to the shoulder balance after AS surgery. This is to achieving shoulder balance using the common radiological measures in patients with AAS. AAS is a three-dimensional pathology again, and it is well known that one of the most important measures of the success in scoliosis surgery is to achievement of the shoulder balance. Although the Lenke classification is widely used to determine the extent of the fusion levels, it is reported that some patients have post-operative shoulder imbalance, even when the curves are well corrected. This is an important aspect because the significant corrective capacity of the spinal instrument may lead to worsening shoulder imbalance post-operatively and lead to unsatisfactory aesthetic outcome. Furthermore, shoulder imbalance is associated with the patient appearance, satisfaction, insecurity, hypersensitivity, and that their psychosocial adjustment was negatively correlated with the severity of the deformity. These reasons make the shoulder balance more important and became a major concern after surgery. But the thing is, the major challenge is how to assess the position of the shoulder during the surgery, because when we do the surgery, the prone position of the patient and the non-physical positioning of the arm during the surgery makes clinical assessment impossible. And the radiologic assessment, the fluoro, imprecise. We can see only in the circle, like a clavicle, first lip, and the T1 vertebral body. During the surgical correction, the surgeon may get a false sense of the shoulder balance. These are the parameters associated with the shoulder balance widely described in the literature, including the radiographic shoulder height, clavicle angle, T1 tilt, and the first rib angle. However, the best radiographic predictors has not yet been determined, and the result is inconsistent. So we would like to assess the radiographic shoulder measures from the preoperative to the postoperative time period, specifically to determine whether which one could be used as an intraoperative proxy for the shoulder balance determination. The inclusion criteria were as follows, and the patient who underwent previous surgery, reoperation, or have the neurological impairments were excluded. The curves were classified using the Lenke classification. The radiographic analysis preoperatively, 2 years postoperative, focuses on the measure of the shoulder balance, T1 tilt, clavicle angle. We try to compare with the radiographic shoulder height. And for this angle, all three measure if the right shoulder is elevated. The measure has a negative value, and if the left shoulder is higher, the measure has a positive value. The Pearson correlation coefficients was used to assess the relationship from the preoperative to 2 years postoperative. The Patty test was used to test the significant difference in the ratio from the preoperative to 2 years postoperative. SPSS 20.0 was used for statistical analysis. The result. The demographic data is the same as the previous talk. And 130 patients had a preoperative normal RSS, this means the shoulder balance. 130 is around 34% mild imbalance, and 81 had moderate imbalance. 39 has severe imbalance, is around 10%. At the final, the follow-up, we found that the patient get normal balance around 60%, only mild around 30%, and the severe and moderate around 10%. Oops. Sorry, I don't know what is going on. So this is a radiographic parameters. The mean radiographic shoulder height is improved. This is a clavicle angle, T1 tilt, and the first rib angle. These parameters are improved significantly after surgery. For the relationships between the shoulder height difference and the clavicle angle, at the preoperative 6 weeks and the last follow-up, more than 2 years, we found that very strong correlation between the two parameters all the time. Moreover, we found that the increasing in the clavicle angle around 4.3 degrees to be associated with the increased shoulder height around 1 millimeters. When we correlate the shoulder height with the parameters like a first rib angle and T1 tilt angle on the here and on the right, we found that the correlation are very small, and it's indicated that little or no relationship between this variable. So patients with the AAS often report dissatisfaction with the waist contour, hip, chest wall rotation, breast, and shoulder balance. As demonstrated by this study, the surgical improvement of the shoulder balance is around 3.9 millimeters, range from 14 to 8 millimeters postoperatively. And our study found that the clavicle angle was strongly correlated with the shoulder balance, which is similar to the Kuko and et al. That he point out that the clavicle angle and the coracoid height were significant predictors for the shoulder balance. From the multivariable linear model adjusting, we found that the marginal increase in the clavicle angle 4.3 degrees to be associated with the increased shoulder height around 1 millimeters. The patient with severe postoperative imbalance show higher preoperative clavicle angle around 15 degrees. Regarding to the medial and lateral shoulder balance concept by the Professor Cure and Professor Ono, there were two distinct regions, the lateral and the medial shoulder balance. The first rib angle and the T1 tilt correlated very well with the medial trapezoidal prominent, but not the lateral shoulder balance. And the lateral region, as reflect the clavicle angle, correlated weakly with the T1 tilt thoracic curve side or thoracic apical deviation from his paper. The reasons why our results found that the T1 tilt demonstrate moderate to weak correlation with the shoulder height difference, because the T1 tilt and the first rib are the medial parameters, but intraoperatively, this parameter might be useful in guiding intraoperatively correction when we correct the proximal curve and the shoulder could not be seen on the full row. This is a retrospective study, lack of data related to the clinical evaluation of the shoulder balance, but it's somewhat minimized by the large number of the patients, single surgeon providing the same technique of the surgery, which permit extensive statistical comparison. So in my summary, the results of this study can help to guide the surgeons who perform posterior spinal fusion for ARS to reduce the chance of postoperative shoulder imbalance, especially the intraoperative imaging of the clavicle angle. The clavicle angle is important parameters to predict the postoperative shoulder balance. However, the first rib angle and T1 tilt are still useful guide for medial shoulder balance. I would like to thank all of my colleagues that they're not present here, and thank you, Department of Orthopedic, Pramukitgaon Hospital, also.
Thank you very much.